Ricket is not seen in children who are suffering from severe acute malnutrition. Why? Because ricket is a disease of growing bone. So ricket is seen in children who are suffering from malnutrition when they are in the rehabilitation. Rickets with increased serum phosphate is seen in, your options are vitamin D dependent rickets, vitamin D resistant ricket, renal osteodystrophy, or it is RTA. Think. Now just change one word. Rickets with increased urine phosphate concentration is seen in which type of ricket? Vitamin D dependent rickets, nutritional rickets, vitamin D resistant rickets, or it is renal osteodystrophy. Totally confused? Basically there are 5 types of rickets. Nutritional rickets, vitamin D dependent type 1 and type 2 rickets, vitamin D resistant rickets, which is also known hypophosphatemic rickets, as well as renal rickets seen in children who are suffering from RTA as well as renal osteodystrophies. Among these 5 types, it is always confusing that which cause increased serum phosphate, which cause increased PTH. Too difficult to understand at a stage, but if you understand pathophysiology of ricket, then these all questions are very easy to use. So do not skip anything, watch till the end. In today's video, we are going to learn vitamin D metabolism as well as rickets, all types of the rickets in a very easy language. Let's start learning. Hi, I am Dr. Triyavira Animalde, pediatrician and consultant neonatologist. I'll be your guide for pediatric subject. If you are new to my channel, please do subscribe and give like to this video because it really motivates me when I see likes on my video. So first question is, what is the active form of vitamin D? Is it cholecalciferol? Is it 24-25 hydroxy vitamin D, or it is 125 hydroxy vitamin D, that is calcitriol, or it is 25 hydroxyl vitamin D? And the correct answer is option C, 125 hydroxy vitamin D, that is also called calcitriol. So if you see the vitamin D, the provitamin form of vitamin D is 2 major forms, that is D2, which comes from the plant ergocalciferol, and D3, which is of animal source, that is called cholecalciferol, while active form is called 125 dihydroxy cholecalciferol, which is called calcitriol because it has 3 OH rings. Let's understand the metabolism and absorption of vitamin D. 7-dehydrocholesterol, which is under the skin in presence of ultraviolet B rays, in presence of sunlight, get transformed into the cholecalciferol, that is vitamin D3. Whatever diet we have taken, from that we received vitamin D3, and supplement we received D2, and this both the forms is cholecalciferol vitamin D3 will go to the liver with the help of 25 hydroxylase enzyme. This is getting converted to 25 hydroxy cholecalciferol, that is known as calcidiol because it has 2 rings, 2 OH rings. Then this substance will go to the kidney, and in the kidney with the presence of 1 alpha hydroxylase, it will get converted to 125 dihydroxy cholecalciferol, that is active form of vitamin D. So calcidiol is the most abundant storage circulatory form. To getting converted from diol to triol, we require this enzyme's rate limiting step, and this calcitriol is biologically active, is responsible for all kind of the physiology caused by the vitamin D. So what all function vitamin D do? That is calcitriol active form will act on the intestine. With the help of the receptor, it increases the absorption of calcium as well as the phosphorus. Similarly, it also reduces the secretion of calcium and phosphorus, and it improves the reabsorption of these two from the renal system. So ultimately the end result will be increase in calcium as well as phosphorus level, and this calcium and phosphorus are responsible for many homeostasis of the body. Calcium is very crucial for many function, and we require some sort of the feedback. So there is one hormone called parathyroid hormone responsible for the homeostasis of the calcium. Whenever there is a decrease in the calcium level, increase in the PTH will occur. This PTH will act on the bone to release the calcium from the bone, and whenever there is a release of the calcium from the bone, there will be a process of bone resorption which will cause increase in the enzyme called alkaline phosphatase. So ultimately, with the help of the parathyroid hormones, the calcium concentration is maintained. It will happen whenever there is a deficiency of vitamin D. This zone of provisional calcification will not be there because there is no calcium. The calcium is all out in the system for the maintenance of the homeostasis. So PTH will increase, the calcium will come out, there will be increase in alkaline phosphatase, there will be defective mineralization, defective growth, which will lead to many deformities, which we are going to learn in upcoming slides. The regulation of vitamin D, calcitriol, is with the two important electrolyte, that is calcium and phosphorus. Calcium will act on PTH and PTH will again act on alpha-1 hydroxylase. Similarly, phosphorus activate alpha-1 hydroxylase. So what are the deformities which are seen in cases of vitamin D deficiency? It causes a defective mineralization and there will be a bony deformity of all sorts. First and foremost is there will be a swelling of costochondral junction in a form of rosary, which is used by many religions for the purpose of worship. So it is called rickety rosary. These are all prominence of the costochondral junction, which looks like beads. There is a Harrison sulcus. Because of a weak bones, the attachment of the diaphragm is seen with the rib, that is called Harrison sulcus. There will be one more deformity which is called pectus excavatum. There will be an external curvature of the sternum. There will be a bowing of the leg, genu varum, genu valgum, or it could be Wine-Sweat deformity, which we are going to learn in upcoming slide. Because of the ricket, there will be a disproportionate short stature. Upper segment will be almost normal and the lower segment will have a reduced in the length. There will be a wrist widening, which is the first sign of the rickets in children. There is a frontal bossing, and because of the frontal bossing as well as the delayed closure of the frontanel, the appearance of the head will be hot cross square bone appearance. There is a presence of craniotabes, which is a softening of skull bones, and there is delayed eruption of the teeth. Genu varum, genu valgum, as well as the Wine-Sweat deformity. So how we are going to remember? In genu varum, see, rum is coming. So remember the bottle of rum is kept in between the legs, so the knees are separated and the curvature of the leg will be like this. While for remembering a genu valgum, remember the bottle of gum. The bottle of gum will stick two knees together and it is also called knock knees. In the gum we have a knock knees and here we have a separated knees. So remember the genu varum with bottle of rum, genu valgum with bottle of gum. In a Wine-Sweat deformity, one leg will have a genu valgum deformity while the other leg will have a genu varum deformity, and it looks like a wine-swept, like the wine has come from this side and given this shape to the legs. These all three could be there in a patient with vitamin D deficiency. So what is this? Remember the bottle of rum to separate the knees, it is genu varum. Gum to stick, so it is genu valgum, and this is normal legs. Many a times asked in exam, so please pay attention over here that what is cupping, splaying and fraying. Cupping is just a concavity which is seen here at the end of the bone, that is called cupping. Splaying is a widening of metaphysis, which is also seen here, and the fraying is a indistinct margin of metaphysis like this. So cupping, splaying and fraying is important radiological marker for diagnosis of rickets. What is RD of vitamin D for the children? It is 400 international unit per day. All are true regarding vitamin D except sunlight is important. Active form is calcitriol. RDA is 400 IU for children, and 1 hydroxylation occur in liver. So we know that these three are correct. Sunlight, active form is triol, and RDA is 400. 1 hydroxylation, 1 alpha hydroxylation occur in kidney and not in liver. In liver, 25 hydroxylation will take place. So here the answer is option D, 1 hydroxylation in liver. The next question is vitamin D maximally found in milk, egg, green leafy vegetable, or it is halibut liver oil. We all know it is a fat soluble vitamin. So, and it is stored in the liver. So obviously the liver is a good source of vitamin D. So maximally it is found in halibut liver oil. So these are the list of the sources: sunlight, egg, oily fish, liver, cheese, milk and mushrooms, as well as tofu are good source of vitamin D. And vitamin D is not found in sufficient quantity. Read question carefully. Not found in sufficient quantity. It is present but not that in that good quantity. Could be milk? Yes, it could be milk. Egg, it is found in sufficient quantity. What about green leafy vegetable? Green leafy vegetable, there is no vitamin D. It is deficient in vitamin D. So this is also out. Here it is present but not in a sufficient quantity, and here it is maximally present. So correct answer is milk. Milk is not a good source of vitamin D. It is in a very less amount vitamin D is found in milk. Which pathway describes the synthesis of metabolically active vitamin D? Is it liver, skin, kidney, gut, kidney, skin, kidney, liver, skin, or it is skin, liver, kidney? We all remember that it starts with the skin, goes to the liver, and then finally it goes to the kidney. So the pathway is skin, liver, and the renal system. So correct answer is option D, skin, liver, and kidney. The next question is, which of the following organ does not have any role in regulating vitamin D metabolism? This is very question, but one of a time it was asked, so I have put it. Liver, lungs, kidney, or skin. Just now we have discussed, the correct answer is option B, lungs. Lungs does not play any kind of role for vitamin D metabolism. The next question is, craniotape is seen. Craniotapes is seen in children in with of the following vitamin deficiency: vitamin D, vitamin A, vitamin C, or it is vitamin E. The correct answer is option A, vitamin D. Rickets with high serum phosphate level is seen in with nutritional vitamin D, familial resistance, vitamin D dependency, or renal osteodystrophy. I'm not going to answer because I'm just going to change one word of this question: high serum versus high urinary. Once you put a urinary phosphate level, high urinary level, the answer will change. So we are going to discuss these questions in detail in upcoming slides. So what are the types of ricket? There are 5 types of the ricket. One is nutritional ricket, another is vitamin D dependent type 1 and type 2 rickets. Vitamin D resistant rickets, which is further divided into 2 parts: familial hypophosphatemic rickets, which is X-linked dominant, and hereditary hypophosphatemic ricket with hypercalciuria, that is autosomal dominant as well as autosomal recessive. And there is renal osteodystrophy, CRF, as well as one more is rickets seen in the children with RTA. Type 1, type 2, type 3 and type 4 will be renal rickets. In will have a RTA with rickets, as well as will have a rickets which is seen in a patient who are suffering from chronic renal failure. So what is happening in a nutritional ricket? We all know either there is no sunlight or either there is no dietary supplement. So the end result will be no raw material to form an active form of vitamin D. This is a nutritional ricket in which we'll have all kind of thing like a reduced blood calcium level, reduced phosphorus level, as well as because of this feedback mechanism we'll have an increased parathyroid hormone, there will be a bone resorption, and there is increased alkaline phosphatase level. Here there will be a normal pH as well as there will be a normal urinary phosphate. So as just now we have discussed, we'll have both the reduction of calcitriol, reduction in calcium phosphatase, but increase in PTH as well as alkaline phosphatase. Okay. The next form is vitamin D dependent type 1. Here the main problem is we have some issue with the 1-alpha hydroxylase enzyme. So conversion from calcidiol to calcitriol will not take place in kidney. This enzyme is defective. So what will be the end result? We all know that there is no vitamin D. There will be a decreased calcium, there will be decreased phosphorus, there will be increased PTH, there will be an increase in alkaline. But here we have an increased calcidiol and reduced calcitriol because there is an issue with 1-alpha hydroxylase. So calcidiol will increase and calcitriol will reduce. So what is going to happen in type 2 ricket? Vitamin D dependent type 2 ricket. Here there is no issue with the alpha hydroxylase. There is nothing wrong with vitamin D. But there is an issue with the intestinal receptor where the absorption of calcium is taking place. So here there is an organ insensitivity in which we do not have absorption from the gastrointestinal system. But the picture would be same. There will be reduced calcium, reduced phosphorus, increased PTH, increased alkaline phosphatase. But in contrast to type 1, where we have a decrease in calcitriol, here it will increase. In contrast to type 1, where only we have increase in diol but not triol, this will have increase in both. So this is the differentiating feature from vitamin D type 1 to type 2. Now the third type, that is called vitamin D resistant ricket, in which there is nothing wrong with vitamin D, but there is something wrong with the phosphate metabolism. This is also called hypophosphatemic rickets. This is further divided into two main parts, that is familial X-linked dominant hypophosphatemic ricket and the hereditary hypophosphatic ricket, which is with hypercalciuria. Here the problem is phosphate is getting removed from the kidney. There is problem with the reabsorption of only phosphorus. There is nothing wrong with the metabolism of the calcium, but calcium and phosphorus always work in combination. So if phosphorus is getting out, there will be a disturbance in the metabolism of the calcium also. So what is happening here in vitamin D resistant ricket? In a first type, familial X-linked hypophosphatemic ricket, there will be a urinary loss of the phosphate. So in a urine concentration, there will be a increased phosphate level and there will be a reduction in the serum phosphate level. But somehow here there will be a normal calcitriol level, because we have learned that whenever there is a reduction in the serum phosphate level, there is a more induction of 1-alpha hydroxylase to produce more calcitriol. But somehow this enzyme is also not getting triggered with this serum phosphate level. So here we'll have a normal calcitriol level. While in hereditary hypophosphatemic ricket with hypercalciuria, because there is a low serum phosphate level, we'll have an induction of 1-alpha hydroxylase enzyme and we'll be having more concentration of calcitriol. So that is main difference between familial X-linked as well as the hereditary hypophosphatemic ricket. One more important fact has to be remembered with the hypophosphatemic ricket is phosphate has nothing to do with the metabolism, with the feedback of parathyroid hormone. Parathyroid hormone have a feedback mechanism with calcium. So in a hypophosphatemic ricket, there is no increase in PTH. PTH level is normal. So among all the rickets, please remember that whenever you see the question with normal parathyroid hormone, think of hypophosphatemic ricket, because phosphate has nothing to do with the feedback mechanism with the PTH. So in a hypophosphatemic ricket, there will be a normal level of PTH, while in rest all types of ricket will have an increased level of PTH because of feedback mechanism. So as we already discussed, in hypophosphatemic ricket, we'll have a normal PTH as well as normal serum calcium. Normal serum calcium will have a decreased serum phosphate. We have increased alkaline phosphate as a part of bone demineralization. We'll have a increased urinary phosphate and we'll have a acidic urinary pH. But the catch point between these two is here we'll have a normal calcitriol while we'll have a increased concentration of calcitriol in hereditary hypophosphatemic ricket. Now the last type is renal type of ricket, that is renal osteodystrophy. Here we all know it occurs in a patient who are suffering from chronic renal failure. So there will be all sign of chronic renal failure, like there will be increase in the serum creatinine as well as blood urea. There will be a presence of acidosis. There will be other signs of chronic renal failure. So in a renal failure, one thing is this enzyme will not work. So vitamin D will be on the lower side, and because of vitamin D is on the lower side, calcium concentration will also reduce. So because of that feedback, PTH will go up, and as the renal is not able to handle the reabsorption of the phosphate, here we'll have a urinary loss of the phosphate. But the difference between the renal osteodystrophy and the hypophosphatemic ricket is here renal osteodystrophy will have an increased PTH, while in a hypophosphatemic rickets will have a normal PTH. Here the serum phosphate level is on the higher side, while in a hypophosphatemic rickets it is on the lower side, and will have all the other sign of renal failure. Now the last type is renal seen in a patient, a ricket seen in a patient of RTA. In a RTA it is multifactorial. Systemic acidosis, so calcium and phosphorus mobilize from the bone for the purpose of buffering, and it will lead to defective mineralization. Here we'll have a reduced serum calcium, reduced serum phosphate, we'll have a reduced concentration of calcitriol, active form of vitamin D, and we'll have a increased PTH because here there is a reduction of the calcium. So because of feedback, the PTH will also increase, there will be a bone demineralization, and there is increase in the alkaline phosphate as well as there will be a systemic acidosis. So how we are going to differentiate this ricket from the renal osteodystrophy? Here in a RTA, there will be acidosis. There also in end stage kidney disease, there could be a acidosis. Main important thing is here the serum phosphate concentration will be on the reduced side, while in a renal osteodystrophy. So now we are going to understand the question from where this all started. Our question was, ricket with high serum phosphate level is seen in which condition? High serum phosphate level is seen only in one condition, where kidney is not able to remove the phosphate, and that is seen in a patient of chronic renal failure, renal osteodystrophy. Nutritional vitamin D deficiency will have a reduced serum phosphate. Familial resistance also will have a reduced. Vitamin D dependent will have a reduced, but in a renal osteodystrophy will have a ricket with a higher serum phosphate concentration. So correct answer is option D, renal osteodystrophy. And this is the table has to be kept in mind to differentiate these two questions. See, in a renal failure, that is renal osteodystrophy. So in a patient of renal failure, that is renal osteodystrophy, will have a serum phosphorus which is on the higher side, and there will be absent of urinary phosphate, in contrast to RTA, where there will be a low serum phosphorus and there will be a high urinary phosphate. Acidosis will be present in both, PTH will be high in both. One more feature which is differentiating from the renal osteodystrophy to RTA is the level of blood urea and serum creatinine. So next question is, ricket with high urinary phosphate level indicates. In a previous question, we have discussed that rickets with high serum phosphate. Here it is high urinary phosphate. Nutritional vitamin D deficiency, familial vitamin D resistant rickets, vitamin D dependent ricket, or it is renal osteodystrophy. Whenever we see the high urinary phosphate, it means there is something wrong with the kidney which cannot able the handle of the reabsorption of the phosphate. So it could be either RTA, or it could be either vitamin D resistant ricket, which is of two type, X-linked as well as autosomal, familial and hereditary. So here there is no mention of RTA. So correct answer is option B, familial D resistant vitamin D deficiency, that is in which we'll get a high urinary phosphate level, because here will not have a proper reabsorption of the phosphorus from the kidney. So if you see the difference between these two, urinary phosphate will be present in both of them, RTA and hypophosphatemic rickets, but the catch point is here, in which we have a normal PTH in hypophosphatemic, high PTH in RTA, as well as RTA the calcium will be low, in hypophosphatemic the calcium will be normal. Vitamin D deficiency, which of the following is not seen? Increased alkaline phosphatase, it is seen as a part of bone demineralization, right? Decreased phosphate in the urine, it is seen. Hypophosphatemia, it is seen. Or it is decreased serum calcium. We all know alkaline phosphatase is increased. Decreased serum calcium is seen. Hypophosphatemia is also seen, but decreased phosphate in urine is not seen. It is only seen in a patient with renal failure. So correct answer is option B, decreased phosphate in urine. The next question is, which of the following condition typically has rickets with normal or low calcium? We are having normal or low calcium, elevated phosphorus, elevated PTH and elevated alkaline phosphatase. We are having here normal or low calcium, increased phosphorus, increased PTH and increased alkaline phosphatase. So in a vitamin D deficiency, we know that vitamin D deficiency will have a low calcium as well as low phosphorus. So option A is out. In a Fanconi syndrome, it is mentioned typically. In a typical Fanconi syndrome, there should be acidosis, glycosuria as well as the proteinuria, which is not mentioned here. So Fanconi is also out. Dent disease is a condition in which we'll have a nephrocalcinosis, hypercalciuria, stone and many other symptoms, which is also not a part of this scenario. So this is also out. Now we are having elevated phosphorus. We have discussed whenever we are having increased serum phosphorus as well as reduced urinary phosphate, CKD or a renal osteodystrophy has to be kept in our mind. So correct answer is option D, chronic kidney disease. The next question is causes of ricket includes all RTA, CKD, benign mesenchymal tumor and severe malnutrition. Just now we have discussed in the beginning of our video that severe malnutrition cannot cause ricket because widening of epiphyses is seen in scurvy, rickets, achondroplasia or osteoporosis. We all know widening of epiphyses is seen in a patient with rickets. It's a very classical finding of most potent form of vitamin D, ergocalciferol, 7-dehydrocalciferol, 25-hydroxycholecalciferol, and it is 1,25-dehydroxycholecalciferol. This is also just a revision. Correct answer is option D, calcitriol or 1,25-dihydroxycholecalciferol. The basic defect in a ricket is excessive ossification, excessive mineralization, defective reabsorption, or it is defective mineralization. With the pathophysiology of ricket, we have learned that it is because of defective mineralization. Which of the following is not a sign of active ricket? Permanent fontanelles, hot cross bun sign, failure to thrive, or subperiosteal hemorrhage? Subperiosteal hemorrhage is a sign of scurvy. It is not a sign of active ricket. Ricket in infant present with all except craniotabs, widened fontanelle, ricketic rosary and bleeding gums. We all know that these three is a presentation of classical rickets, while bleeding gums is presentation of scurvy. True about nutritional rickets except is all except craniotabs, multiple fracture, wrist widening and increased serum phosphate. We all know that increased serum phosphate is not seen in a nutritional ricket. Increased concentration of serum phosphate is seen in a patient with chronic renal failure or renal osteodystrophy. It is just a revision. Whenever there is increased serum phosphate concentration, it means it is renal osteodystrophy. All of the following is seen in the rickets except bow legs, gum bleeding, pot belly and craniotabs. Bow leg is seen, gum bleeding is not seen, pot belly is also seen and craniotab is also seen. So correct answer is option B, gum bleeding. Wind-swept deformity is seen in scurvy, rickets, osteoporosis, achondroplasia. This is wind-swept deformity like genu varum and genu valgum. It can also be part of vitamin D deficiency. We all know the correct answer is option B, rickets. A 2-year-old boy has clinical feature of rickets. His investigation revealed serum calcium of 9, phosphate of 2.4 which is on the lower side, alkaline phosphate is 104 that is on the 1040 that is on the higher side, and there is a normal PTH. Bicarbonate is 22. Which of the following is the probable diagnosis? C. This is also just a revision of the previous fundamentals which we have learned. Distal RTA. In RTA, there should be a presence of acidosis, right? Here we have a normal bicarb level. So this option is bicarb is normal, so option A is out. In a hypophosphatemic ricket, is it possible? Yes, it could be possible because there is a normal PTH. That is the only ricket which will have a normal PTH level. So it could be possible. Calcium and PTH normal and low phosphorus. Yes, so B could be our option. Now let's review option C and option D. What will happen in vitamin D dependent ricket? Vitamin D dependent ricket will have a low serum calcium and high PTH. So this is also out. And what about hypoparathyroidism? Hypoparathyroidism will present is a low PTH. Here it is normal PTH. So this option is also out. So correct answer is option B, hypophosphatemic ricket. This is the way we can differentiate. We have to see the level of serum phosphate. If the serum phosphate is on the higher side, we all know it is because of CRF. If it is normal or low, we need to see the blood pH. If the blood pH is low and there is a presence of acidosis, this is RTA. If there is normal blood pH, we have to see PTH and calcium. If PTH is normal and calcium is also normal, then it is hypophosphatemic ricket. If we see the high PTH and low calcium, it is vitamin D dependent type 1 or type 2 rickets. And further differentiation between type 1 and type 2, in type 1 diol will increase, in type 2 both diol and triol both will increase. So next question is, 10 years old boy has a fractured femur. Biochemical evaluation revealed HB of 11.5, ESR of 18, serum calcium is 12.8, serum phosphorus is 2.3, alkaline phosphatase is 140, and blood urea is 32. Which of the following is the most probable diagnosis? What we are having here? So here we have a higher level of serum calcium, which is not possible in a patient with nutritional rickets. So option A is out. It is not seen in a patient of renal rickets, CRF of or a renal osteodystrophy, because there is altered RFT should be there. Here the blood urea is normal. Hyperparathyroidism can be the answer because high calcium is a clue. 12.8 is on the higher side. And skeletal dysplasia will have many other features to manifest, so this is also out. So correct answer is option C, hyperparathyroid. So that's all about today's lecture. I hope you all understood and learnt well. Your suggestions are always welcome. Please let me know what else you would like to learn from me. Till that time, take care of yourself, study hard as well as study smart.